welcome all dignitaries and delegates to this innovative session of MAHA-IAP. MAHA-IAP is celebrating IAP Adolescent Week from 7th to 14th November 2022. The theme of this week is promoting adolescent-friendly healthcare. So, in continuation with this, we have organized a three-step training workshop for all the general practitioners, which will be helpful to them in their office practice. With this workshop this workshop we are involving the galaxy of speakers from Maharashtra who are national, international experts in their own field. So now I hand over to Dr. Ram Bharat, who is today's moderator for further proceedings. Dr. Ram Bharat is practicing pediatrician and neonatologist in Chandrapur since last 15 years. Currently, he is Chandrapur District Coordinator for Adolescent Health Academy, Nagpur. Over to you, Dr. Ram Bharat, sir. Thank you. Unmute kara, sir. Sir, unmute kara. Ram, sir, unmute kara. Start.
Good afternoon, everyone. On occasion of National Adolescent Health Week, I, Dr. Ram Bharat, moderator for this wonderful workshop, welcome all of you in this three-step training program of Maharashtra IAP. As we all are aware, adolescence is very crucial period for physical, emotional, mental, and social well-being and development. As children grow and reach to adolescent phase or teenage, the brain goes through significant developmental changes and that will last throughout the life. Adolescents become more independent and they start forming their new identity. Emotional highs and lows persist, and these mental and physical changes underlie the importance of meeting adolescents' physical, emotional, and mental health needs. So, keeping all these things in mind, we have arranged this unique workshop for adolescent in OPD practice, which is in 3 steps. In this workshop, we are going to cover adolescent mental health issues with unique combination of clinical expertise as well as counseling with special reference of cognitive behavioral therapy as well as effective medication. So, with this introduction, I just introduce, we are blessed with 2 chairpersons for this wonderful workshop. The first chairperson is our beloved and our guiding force and our leader, Dr. Hemant Gangulia sir. Dr. Hemant Gangulia sir needs no introduction, but Dr. Hemant Gangulia sir is from Nerar district, Raigad, and he is practicing there since last 31 years. Along with pediatrician and academician, he is a medico-legal expert. Sir is a secretary of Maharashtra. Sir is Maharashtra Secretary of Indian Medical Legal and Ethics Association of 2022. Sir is President of Maharashtra IAP for this year 2022. Sir has held important posts like he was past President of IAP Raigad branch in 2018 to 2020. He was ex Maharashtra IAP board member. He has conducted medical legal ethical conference in 2020 where he was scientific secretary and was instrumental in organizing this event. Sir was chief organizing chairperson of Mahapedicon 2021, and sir received the prestigious Lifetime Achievement Award in Arogya Darpan in on the Doctor's Day of 2017. Sir has organized and sir has conducted various CMEs and conferences and also conducted a virtual Zoom question and answer and quiz sessions. Welcome, Dr. Hemant Gangulia, sir. Our second esteemed chairperson for this workshop is none other than Dr. Ramakant Patil, sir, from Nashik. He is founder of Nelson Hospital, Nashik. He was past vice president of IMA Nashik. He was past Maharashtra IIP secretary, past IIP Nashik branch president. Sir was executive board member of Central IIP of 2022. Sir is organizing chairperson of Mahapedicon 2022, which is going to be organized very shortly in Nashik. And along with that, sir has special interest in critical care and asthma. Also, sir is trekker, runner, and cyclist. So we are blessed with these two great academicians as well as social workers as well as multi-talented personalities as a chairperson. First of all, I invite Dr. Hemant Gangulia, sir, to express his view on the today's topic, that is adolescent in office practice. Over to you, Dr. Hemant Gangulia, sir.
Thank you very much, Dr. Ram Bharat, for so much elaborate introductions. Need not say so much, only one or two lines is sufficient. But anyway, thanks for that, and good afternoon, each and everyone. The excellent faculty which we are having, as in form of Dr. Samir Dalwai sir, Dr. Suchit Tamboli sir, and Dr. Jayashree madam, all equal to the national, international expertise. We can say them all three are the dynamic personalities in the field of adolescence, as well as a moderator is an excellent practitioner from Chandrapur and is a district coordinator of Chandrapur for AHA Nagpur also, as well as my secretary, Dr. Amol Pawar. And this issue, what we are discussing, and all the attendees who are on this Zoom platform, as well as who are seeing on the YouTube channel. It's a great initiative as well, because the theme of this Adolescent Week is promoting adolescent-friendly healthcare. And in this era, we are seeing lots of adolescent in our practice also. So how to approach, and it's a very need of the hour, how to approach, because also legality is also there in view of, so POXO Acts is there, everything, and lots of reasons are there. So how to handle these all adolescent issues which are growing more and more in view of the so many social media around, Twitter, Instagram, and WhatsApp and whatnot. All the social media, all contributors. So it's a very multi-dimensional field where one needs to be very particular and comfortable in handling this issue. So I'm very much sure with all this galaxy of experts, we will be having a good learning session to have the how to deal with the adolescent issues in our OPD practice. As well as I thank Dr. Neha, all coordinating all the things, making wonderful drafts, flyers, Dr. Vishal, as well as Dr. Pallavi, Madam Pallavi, to give the all technical support, whatever, for this program. Thank you very much. Thank you, Dr. Ram, sir.
Thank you, Dr. Hemant, sir, for always guiding and encouraging us. Now, I request Dr. Ramakant Patil, sir, the second chairperson for this workshop, to express his views on this topic, adolescent in office practice.
Thank you, Dr. Ram. Respected President, Dr. Gangulia, sir, my friend, colleague, Dr. Amol, again, friend, philosopher, mentor, Dr. Samir Dalwai, my college friend in BJMC Pune, Dr. Suchit Tamboli, and Jayashree madam. It is great honor to be invited as chairperson and to share with Dr. Gangulia, sir. Friends, India is youngest country. We have got 25.3 million to 253 million, that is 25.3 crore adolescent, and nearly 42 crores below 19 years of age. So this country is youngest country, and government of India has launched a Rashtriya Kishore Swasthya Karyakram along with Rashtriya Bal Swasthya Karyakram. So we need to go beyond just the health, physical health problem, but other issues of adolescent health. And very aptly, the topics and the luminaries are there for this program, and wonderful 3-step I think it has been the brainchild of these luminaries that adolescent in OPD, what to do. I will, it will be a best uh, a, thing, the deliberation which we might will be hearing. Also, counseling, we have all heard counseling, but what to tell exactly, that will be told to us. And simple use of medication, because we very rarely, we don't have any, there is no role for medication in adolescent health unless until in preventive acne and small things. But still, what medication, if at all to be used, will be told to us by Suchit Tamboli. So I wish all the best for this wonderful session. And thank you, Dr. Ram Bharat and Amol Pawar, for inviting me. Over to Dr. Ram.
Thank you, sir. It's really a time need for us to go beyond government programs and do concrete things for adolescent health. Now, let us start with our today's workshop, which is three-step workshop. In this first step, now an adolescent has come to our OPD. How to approach, how to diagnose. So, to enlighten us on this topic, on this vital topic, which is first step of adolescent management, we have esteemed speaker, Dr. Samir Hassan Dalwai sir, who is a developmental and behavioral pediatrician who has dedicated his career to deliver contemporary intervention for children with special needs and their families. He is recipient of prestigious Government of India's Rajiv Gandhi Manav Seva Award for his social service in 2012. He is founder, director, and consultant at New Horizon Child Development Center, Mumbai, which is developmental pediatrician and led multidisciplinary center with 5 centers and online intervention programs for children with special needs. He and his team proposed the social interaction theory for autism as well as social communication sequence of development. His current work is delivering online intervention program for children with special need. He is national treasurer of Indian Academy of Pediatrics, past chairperson of IIP chapter of neurodevelopmental pediatrics and past president of IIP Mumbai. He is editor-in-chief of IIP Handbook of Behavioral Pediatrics. He served member of Government of Maharashtra Pediatric Task COVID Force, and he has numerous publications to his credit and delivered guest lectures across India and all over the world. He is attached to Nanavati Hospital, Mumbai. Sir, with this short introduction, may I request Dr. Samir Dalwai sir for his enlightening talk for all of us. One important announcement here I want to do. Since Dr. Samir Dalwai sir has to attend another academic workshop shortly, so sir won't be with us after his talk. So I request all of the attending pediatricians, if you have any question on Dr. Samir Dalwai sir's topic, that is adolescent in OPD practice, you please enter them in chat box. Dr. Samir Dalwai sir's question answer session will be soon after his talk. Over to you, Dr. Samir sir.
Namaskar and thank you, dear Rambo. Thank you so much for the kind introduction, and good afternoon, respected President sir, Dr. Gangolia ji, Dr. Amol Pawar sir, the secretary, my dear colleague and elder brother from the EB, Dr. Ramakant Patil Sahib, all the respected co-faculties, Dr. Shivalkar, my dear Dr. Suchit Tamboli sir, all the respected luminaries from all across the country, my dear friend and mentor, Professor Dr. V.N. Tripathi ji from Kanpur, Namaskar sir, and all the seniors from all over Maharashtra and all over India. Thank you for attending for this session. When Dr. Amol and Dr. Jaya spoke and said that we wanted to do something for adolescents, I thought we must do something which is very, very basic and very, very simple, because none of us want to be psychologists or psychiatrists. Fortunately, we all are happy to be pediatricians. And hence the idea was, what could we as pediatricians do for adolescent children in our clinic rather than just having to feel helpless and end up referring these children. So the topics have been planned in the way that what is it that we as pediatricians will do in our OPD without having to refer or need anybody else for handling these children. And hence, there are 3 steps. The first step is which I will be taking. A child, an adolescent actually has walked into the OPD. What will we do? So going ahead, we know that adolescents constitute a special group for multiple reasons. But adolescents with behavioral problems constitute a subspecialty within this group because it is often clouded in myths, prejudices, biases about adolescents, confusion. Practical issues in the management begin with issues in appropriate diagnosis actually and clinical approach related to the behavior of the child. And though there are many other practical issues besides behavior, we shall focus on the above. And hence, what we are looking at is how to arrive at a clinical diagnosis. The first message is the history also tells you the intervention in an adolescence. The history that you take is so important that by itself you will know what you have to do in the intervention, because the history will reveal to you a lot of wrong or unfortunate stuff that is happening with the child, which itself is enough for you to intervene and improve the child. So there itself is the first message. You don't need to refer anybody with a behavioral problem to anybody. Whatever I'm going to speak today is all practical experience from my centers, nothing theoretical. So if I am wrong on some count, I expect and request all of you to pardon me for the same. Most of this is data from 2003 onwards. So we have collated data from 2009, about 7,000 children till 2019 in our child development centers. So here is what happens. You are in your OPD this evening after the session. You will go to your clinic and 12-year-old adolescent male is brought to you. Mother says the school counselor has asked her to see a specialist for his behavior. What will you do? So now, ideally, this should have been a very interactive workshop. So we cannot because of the limitation. But I would request you to keep thinking in your mind and keep speaking up, even if you are on mute. What do you think you would do? So if this is a scene, what will you do? Options are refer to a psychologist or to a behavioral therapist or developmental behavioral pediatrician or pediatrician with expertise in adolescence. Counsel the parent ki be nice to the child. Don't be bad, be kind to your child. Otherwise, counsel the child to be nice and kind to the parents. Depends on what you are facing with your child or grandchild at home currently. All the above, none of the above. So if you see, all of these options keep changing from time to time according to the current fashion. Ideally, I would say none of the above is right, because what the right thing to do is ask. What will you ask? Mom or dad or grandparent, whoever is there, what kind of behavior do you think is problematic? Just because somebody says there's a behavioral problem, don't label as difficult adolescent and refer the child. Now, when you ask the mother what kind of behavior do you think is the problem, there are 4 options that the mother can say. First, she does not find anything problematic with the child. वो school counselor बच्चे को label कर रही है. Or she thinks he does not listen to her. That's the behavioral problem. Or she thinks he is an aggressive adolescent. Or fourth, she thinks he does not study enough. Now let us take that history and each of these. Let's go to scenario 1. 12-year-old adolescent comes to you with query behavioral problem. Mother does not find anything problematic with the child. Now, how will you proceed? When you take a further history, he is found disturbing others in the classroom, playing the fool, loves making others laugh, thrives in the attention he gets in the classroom, but he is good at his studies and scores well. So what would you think? Unfortunately, we can't take answers, but I would like you to think in your own mind, and maybe in the chat box, you can keep typing in whatever are your answers and we will see how that goes. Now, if you see this child, one would attempt to say that there is no problem with this child. Everything is okay and fine. When you go ahead, you will also see that the mother says she does not agree with the school counselor. They are unnecessarily targeting the child. And she would say nothing is wrong with the child. Now, when the mother does not find anything problematic, but somewhere there is a concern, make very sure that you are dealing with the reality and not some imagination. Because in India, it's very common, most countries actually, to find that the mother is overtly protective about the child. Sari dunya mere bete ko chahe jo kahe, lekin mera bachcha to ekdam perfect hai. And hence it's very important, especially in the adolescent group, to ask the significant others like the peers, the teachers, the colleagues, and the neighbors and everybody else who may be able to give you some history. But very important, never ever forget to ask the adolescent personally, what are the problems that the child is facing? So we are going to talk about such simple issues, not necessarily some big diagnostic labels. as to what is the approach we must have. And the message from the scenario 1 is, do not rush to give a label. Very important, don't forget to ask the adolescent what this means. आणि हा चांगला गोंडस दिसणारा मुलगा डॉक्टर अमोल पवार लहानपणाचा नाही बरं का. Scenario 2, the mother thinks he does not listen to her. The 12-year-old child brought for behavioral complaints. Mother's scenario is that he does not listen to her. आता listen to her जर करत नसेल तर you have to ask in detail. Listen नहीं करता है मतलब क्या, कान से नहीं सुनता है, अरे 10 बार चिल्लाती हो उसको सुनाई नहीं ऐसा बिहेव करता है, या दिमाग से नहीं सुनता है. डॉक्टर साहब सुनता तो है लेकिन उसके समझ में नहीं आता है क्या करना है, इसलिए कुछ भी करते रहता है. डॉक्टर साहब समझता है, जानता है मैं क्या कह रही हूं, लेकिन उसकी हरकतों से बाज नहीं आएगा, जानबूझ के वही करेगा. और फाइनली दिल से डॉक्टर साहब वो सुनता भी है, समझता भी है, अपनी हरकतें कंट्रोल भी कर सकता, दोस्तों के साथ बहुत अच्छा है, मगर मेरी जान लेने के लिए आया हुआ है इसलिए नहीं मानता है. So these are simple issues that you need to ask, because all of them could actually have a different etiology and a line of management. So within scenario 2, does not listen to the mother. The scenario 2A is, पहले सुनता था, अगोदर ऐकत होता, आता ऐकत नाही. Now he does not listen. Now this is very important, because the first thing of course you will do is check hearing. And please remember, hearing impairment is not only congenital, it can be acquired in early childhood or mid childhood or even early adolescence as well. Also check what she means by this. सुनता नहीं है मतलब क्या है. डॉक्टर साहब उसको मैं बोलती हूँ, उसको अरे तू स्कूल से घर आएगा ना तो जाके अपने जूते निकाल, कपड़े चेंज कर, प्लेट रखी है, खाना निकालो, गरम करो, अपने आप निकाल के खाओ, बाद में फोन आएगा, फोन मत उठाना, बाहर अपना पेट डॉग भी है उसको भी खाना खिलाना, दादी जी की दवाई बराबर से दे देना, और फोन मत उठाना, दोस्तों से बात मत करना. अब ये अगर माँ कहती है कि मैंने कहा है और he does not listen to this, you know where the problem is. It is certainly not with the child. So your counseling will be more to guide the mother कि भाई adolescents cannot listen to such long messages. Just give small messages at a time. What does she expect? Ask her examples. आप सुनता नहीं मतलब चाहते क्या हो? डॉक्टर साहब पहले तो हर बात मेरी मानता था, अब कुछ नहीं मानता. अच्छा पहले मतलब कब? जब वो 4 साल का था. अब क्या उम्र है उसकी? 12 साल. So obviously you have to explain to her that a 4-year-old child's cognitive, behavioral, emotional status is totally different. At 4 years, the mother is the role model. At 12 years, she is the villain model. So he's not going to follow her. And very important, since when is this happening? If he's not listening now, and is it getting worse, or it was getting worse, but now it is bettering? It's very important to ask this history. More important, what is the loss? सुनता नहीं है तो नुकसान क्या है? तकलीफ क्या है? Is it affecting the child's health? डॉक्टर साहब वो कुछ नहीं खाना खाता है, दिन भर क्या करता है पता नहीं, खाना नहीं खा रहा है, उसका वजन कम हो रहा है. पिछले बार आपके क्लिनिक में आई थी, उसका 45 किलो वजन था, अभी 38 हो गया है. देयर इज अ डेफिनेट कंसर्न विद द हेल्थ. माइंड, डॉक्टर साहब वो 2-3 दिन रूम के बाहर नहीं आता है, खाने की प्लेट देनी पड़ती है, अंदर क्या खाता है नहीं खाता है, चाबी लगा के निकल जाता है और स्कूल जाएगा. तब कभी एक बार हमने डुप्लीकेट चाबी से रूम खोला, अंदर आप देखेंगे मुझे शॉक हो गया कैसे कंडीशन में रूम था. Is there some problem with his thinking? Finally, is there a loss of money? डॉक्टर साहब हर हफ्ते, हर 2 हफ्ते में 2,000-3,000 रुपया इधर उधर मिसिंग है. Now, this is very significant. Is he into some substance abuse? Now, very important issue. What does she tell him such, or how does she tell him that he does not? आप बता दे क्या बोलते कैसे बच्चों को आप आपके. There are some mothers who give instruction 1 hourly, like some medication, and the child does not listen, obviously. And there are some who give instruction once a year, like Warren Buffett writes a letter once a year to his CEOs, and the mother expects the child will follow her throughout the year. Or whether she tells him in either overtly authoritarian voice or while weeping profusely, मैं बेचारी माँ तुम्हारे लिए मेरी जिंदगी sacrifice कर रही हूँ, ये तुम्हारे father को कुछ पड़ी नहीं है, तुम्हें कुछ पड़ी नहीं है. These are all issues which are very important. Again, is she always telling him how terrible he is, just like his father or grandfather? या grandfather मतलब दादाजी. And on the other hand, comparing how nice his sibling, cousin, classmate, grandfather, यहाँ पे नाना जी, और how nice Sachin Tendulkar is, और how Sachin Pilgaonkar is, और how our dear जो डॉक्टर जैसे आपके जो डॉक्टर होते हैं, डॉक्टर उपेंद्र किंजरोडकर कितने अच्छे हैं, तुम वैसे क्यों नहीं हो सकते हो? Is this complaining always going on? Is this complaining or talking to the child, बेटा ये करो ये मत करो, in front of an audience? Whenever he comes home with 3 school friends, is that the time she is talking to him? Is she telling him कि डॉक्टर बेटा 5 साल के बाद तुम्हें एडमिशन लेनी है, तुम्हें डॉक्टर बनना है, तुम्हें इंजीनियर बनना है? Because adolescents cannot comprehend 5-year plans. और खाना खाने बैठे, the mother starts with so much of complaints, जैसे खाना खाने के बाद कोई सैलाब आने वाला है या कोई earthquake होने वाला है. तो ये सब चीजें are very important because this is actually ongoing trauma to the child. And hence, rather than referring first to anybody else for some hi-fi diagnosis, you need to counsel the parents that please stop this kind of behavior. And you need to explain to them what is worsening the child is this behavior in the environment rather than any pathology with the child. Now, if he doesn't listen to mother, who does he listen to? डॉक्टर साहब दोस्तों का ही सुनता है या दिन भर वो मीडिया में कुछ पढ़ता है, वही करता है कि मुझे पैसा बनाना है, मैंने मीडिया पे पढ़ लिया कि मुझे शेयर मार्केट जाना है. The point is, tell the parents that don't try to stop this because you are unlikely to succeed. Because today's adolescents are unlikely to get off their peers or social media. But very important, ask them, does he say कि मुझे भगवान मुझसे बात कर रहे हैं? Does he hear voices? Does he hear dead people talking to him? Does he hear spirits talking to him? Because quite often, very rarely, but often, with some of these difficulties, you may find some early onset of a disorder like a schizophrenia as well. So it's very important. आपकी नहीं सुनता तो किसकी सुनता है? Now scenario 2B, he does not listen to anyone else either, neither the teachers nor peers. So it's not just कि माँ की बात नहीं सुनता है, किसी की भी बात नहीं सुनता है. अब this is interesting because this has been going on forever since childhood. In fact, he spoke late after speech therapy. He speaks less and usually set favorite pattern phrases. ये speech therapy की देन है. जो बायहार्ट करके सिखाया वो बच्चा बोलता है, बाकी नहीं बात करता है. So the first 2A was he was not listening to the mother. Here he is not listening to anyone at all. But he also does not like spending time with peers. He has no friends, sit alone in the class and school bus. He does not like spending time with family and relatives either. He prefers to solve 1,000-piece puzzles or watches YouTube all the time. This is very important. Mother thinks मेरा बच्चा is an unrecognized genius. वो आइंस्टाइन की कॉपी है, सिर्फ लोगों को समझ नहीं आ रहा है. It's very important in this scene to inquire and examine and counsel the mother. First, if he was never listening, of course, check vision and of course hearing. Now, this is what I call check SRK sign. SRK sign stands for Shah Rukh Khan sign. What is Shah Rukh Khan sign? When Shah Rukh Khan does this, the heroine immediately understands that he wants to give her a hug. So she will run into his arms and give him a hug. This, in difficult developmental jargon, is called social reciprocity. Don't call it all these terms, just call it SRK sign. SRK sign being there, being positive, is a normal development because all children, especially younger children, not necessarily adolescents with their parents, mind you, will have shown SRK sign in early childhood. An absence of that in early childhood should lead you to suspect autism, in which case you have to counsel the parents, refer to a developmental pediatrician or adolescent expert. Medications may be needed, but you as a pediatrician continue to monitor this child, please, and do not outsource it to any one of us. Scenario 3, the mother thinks the child is aggressive. We have finished 2 scenarios. Now we come to the case where the mother thinks the child is aggressive. Behavior is aggressive. She thinks he is aggressive. Describe these acts of aggression. Aggression means क्या करता है? डॉक्टर साहब मैं उसको बहुत चिल्लाऊंगी ना, ऐसे मेरी तरफ बहुत गुस्से से देखता है, बहुत aggressive है. What would you say? I don't think this is aggression at all. और डॉक्टर साहब मैंने कुछ किया भी नहीं, आके मुझे भी मारता है, बहन को भी मारता है, भाई को भी मारता है, दादी को भी मारता है. Now that's a difference. What was the nature of injury? डॉक्टर ये सबको मारते रहता है, दिखाइए कहाँ लगा है आपको? नहीं डॉक्टर साहब वो थोड़ा सा मतलब स्क्रैच हुआ था, कल ही अभी निकल गया. You can imagine. What was the provocation? डॉक्टर साहब मेरा बच्चा स्कूल में हमेशा लड़के आता है. Provocation may be that he is being teased for his color of his skin, for his complexion, for his height, for his weight, for the shape of his nose. चश्मा लगाया था तो कोई बैटरी बोल रहा है. For 1 year, 2 years, 3 years, children have been bullying him and teasing him. And then finally one day he lost it. That's not aggressive. And what was the behavior of the child post the aggression? डॉक्टर साहब इतना गुस्सा होता है, चिल्लाता है, मारता है, लेकिन 5 मिनट के बाद शांत होता है, आके मम्मी सॉरी बोल जाता है. डिफरेंट सीन. यार डॉक्टर साहब कुछ फर्क नहीं पड़ता है, उसके बाद मुझे ही जाके सॉरी बोलना पड़ता है, वरना और पीटेगा. Now this is the history that is very important. And hence old-fashioned onset, duration, progress. Is the aggression sudden in the last few weeks or days, or has it been gradual? What is the duration? Was it since early childhood, or is it actually an adolescent onset aggression? What is the progress? It is static, thoda aggressive hai, it's not increasing much, or it's worsening, or it's getting better. So scenario 3A, child has a behavioral problem, mother says is aggressive. What will we look at? 3A, he was a calm child, suddenly began to have outbursts since the past 6 months. And since the last 6 months, it is worsening. Earlier, he was never aggressive. He never had a behavioral problem. He was a calm child. Sudden change, suddenly in 6 months. Very important. Again, vision and hearing, but thorough history and medical examination is very important because these are the neurometabolic diseases that may come up at this age. A late presentation, no doubt, of some neurological conditions, but even a Wilson could present a little late and could have been missed earlier, or an SSPE may be coming up. So you need to rule out all these things, rule out social deprivation, suddenly severe bullying happening in college or school rather, suddenly having changed the classes or has changed the residence in the new area where he has gone, lack of the earlier social comfort zone, and now he's being bullied where he has gone. So all this is very important for us to understand. And very important, any sudden change, rule out abuse, addiction, and poisoning. Poisoning may need not necessarily be by some enemy. It can be the child is using some addictive substances which are contaminated with some poisoning. Again, you have to counsel the parents about all this, investigate thoroughly. This is a child you need to investigate thoroughly. You have to be supportive of the parents because rehabilitation process is very, very difficult for the family as well as a child. And another child here who may require medications, again, don't outsource it and send it away. You need to monitor. 3B, he was never a calm child, always hyperactive and impulsive since childhood. Worsened over the years, started showing resistance to following instructions, first at home, then in the neighborhood, then in the school, started breaking the rules, got into fights with peers, later with the teachers. The friend circle has changed over grades. Earlier, all the good children were his friends. Now, all similar boys are friends. He runs a gang in school. This is interesting. Academics was good initially, but now the behavioral problem has started. Even after that, now even academics has started suffering. So academics was not bad earlier. After behavioral depredation, academics has started suffering. And the girl in the class told her friends that he asked her to accompany him after school for lunch on a date or something like that. And she then saw him smoking as well. So she came and told all his friends. This is the classic road to perdition story that we need to understand. And hence we need to keep in mind, again, vision and hearing is common, but what this child was displaying was poor self-regulation skills. And then you have to suspect an ADHD or ADHD plus like oppositional defiant behavior, conduct disorder. All this will come in, which you need to counsel the parents very calmly that, look, this is something that at home, stop all the earlier things that we discussed in the first scenario and second scenario that's going on. At the same time, refer this child, set goals. Goals have to be separate goals for behavioral, separate for academic, specifically written down, spell it out, put it down in paper. Behavioral, what are the goals for self-improvement as well as improvement in the social behavior with others? Simple things like activities of daily living, taking a bath on time, brushing one's teeth, all these things could be a problem. You need to put them down. And very important, after you make the schedule, you need to have a rewards and consequences policy for the child. This child may need medications. Again, what is common to all the children, I say, is always remember that you have to monitor the child. It is your child. Don't outsource it and send him away. The last scenario, scenario 4. Everything else is fine, not aggressive, listens to the mother, everything is good. But the mother thinks he has some behavioral issues and he does not study enough. This is not strictly a behavioral issue, but in Asia and India, perhaps the most important behavioral issue कि प्रॉब्लम क्या है बच्चे के साथ, क्या ठीक नहीं बच्चे का, तो पढ़ाई ठीक नहीं करता. Now that's why I said thinks into inverted commas. She thinks he does not study enough. What are the actual marks he gets? मम्मी कितने मार्क मिलते हैं? डॉक्टर साहब अभी पहले 99 मिलते थे लेकिन अभी बहुत ही खराब हो गया. कितने मिलते हैं? अभी डॉक्टर 97.5 मिलते हैं. Be very sure you are not dealing with such a fraud case. What are the RC studies in front of her? डॉक्टर साहब वो पढ़ाई करता ही नहीं है, because half the time he is getting up and going here or there. And very important, in a city like Mumbai or Pune or Nasik, you will see 8 hours, 6 hours of school, 1 hour to go to school, 1 hour to come back, 3 hours of tuitions, again half an hour to go there, come back, travel time, 12, 13, 14 hours, the child is just busy with all these things. When do you think will he study enough? So mother says, hardly आधा घंटा पढ़ाई करता है मेरे सामने. अरे बाकी 12 घंटा क्या कर रहा था? पढ़ाई के पीछे तो भाग रहा था बेचारा. So this is very important in this scenario. 4A, you have to learn how to make a difference or differentiate between these children and know that you do not miss the diagnosis. Same. He doesn't seem to learn what is being taught. He seems to have a learning disability. किसी ने बोला है कोई स्मार्ट काउंसलर ने स्कूल में बोल दिया लर्निंग डिफिकल्टी है बच्चे को. 4A, unable to keep up with his peers socially, at play, at academics, lagging behind, always has been a little slow. He needs repeated instructions. नेहमी सांगावं लागतं त्याला, सांगितल्यावर मात्र करतो नेहमी. He does better with one-on-one attention. नाही, मी त्याच्याबरोबर बसले ना डॉक्टर की तो व्यवस्थित करतो. अगर मैं बैठ के रहूंगी डॉक्टर, लेकिन मैं निकल के गई ऑफिस, खत्म हो गया, कुछ नहीं करेगा. Nothing significant on medical history except mild developmental delay. I have put medical history in italics. अच्छा, मेडिकल हिस्ट्री मतलब डेवलपमेंट डिले, डिड नॉट क्राई एट बर्थ, सीजर्स. बाकी ये अब तक हम बात कर रहे थे क्या पॉलिटिकल हिस्ट्री थी, अरे ये भी मेडिकल हिस्ट्री है. सो डोंट इग्नोर ऑल दिस हिस्ट्री दैट वी हैव स्पोकन सो फार. Inquire and examine this child, again vision and hearings, and you will find poor adaptive skills. Mother may teach him in the house in one way, the tuition teacher may teach in one way. When he goes to school, the question paper comes in a little different way. He is not able to adapt that same thing there. In the house, his behavior may be normal. In regular friend circle, it is normal. New situation, he is not able to adapt. This is where you will suspect mild intellectual disability. Counsel the parents that this is not a serious problem, but the problem is you need to identify what is a child's level. Start at where the child is, set up goals one after the other to take the child ahead from where he is, and not necessarily to pull up the child to the class or the level that you expect. And this child will be benefited by one-on-one intervention. So I have so many examples. We are sending him to counselor and to remedial educator. कितने बच्चे? 12 बच्चे एक साथ में काउंसलिंग के लिए, या रेमेडियल के लिए 25 बच्चे. That's not going to help the child. And if there is a problem that you find not getting better, you may need to refer for a diagnosis. Again, very common, my dear friends. We have to keep monitoring these children, because this is a sad story that came to my clinic. He came to me at the age of around 8 or 9 years. He had been going from one pillar to the post, multiple doctors, psychologists, special educators, remedial educators, occupational therapy, speech therapy. सब हो चुका. अच्छा, थोड़ा प्रॉब्लम है, नहीं है, कुछ है, नहीं है. Very classical history of family history of multiple fetal losses, similar history in the maternal side of the family, typical clinical features which may not be dysmorphic features, are not very easy in the earlier age. They may be picked up only in the adolescence age. Typical macroorchidism that we talk about, Fragile X, is only seen after adolescence. So this is a child that we picked up. Please remember, this is a typical child of 4A. 4B, same thing, does not seem to learn what is being taught, has a learning difficulty. Look at his story, similar to 4A. In addition, has a history of strong global developmental delay. He has difficulty in walking and using his hand for writing. Eventful parent did not cry immediately after birth. NICU for 2 months. He had multiple seizures. He was on the ventilator, or he has dysmorphic features. Yes, you guessed it right. This is probably a child who's ended up with cerebral palsy or something like that. So again, vision and hearing, seizures, so electrophysiology, neuroimaging, genetic evaluations for this child, medications for this child. This is a child who will need also pediatric neurologist as well. And again, it's your child, your patient, your adolescent. You need to keep monitoring this child. Scenario 4C, same, doesn't seem to learn, learning difficulty hai, tala disability LD asavi, Dr. Saheb, tala dyslexia hai ka. Take the history. This child is good at all day-to-day aspects of life. He's not slow. He is very good socially as well as intellectually. No significant birth history, no development history, no dysmorphology. Examination largely normal, but some confusion with right and left side, above, below, right, left, ulti chapla ulta ghalto, writing madhe problem hai. Some confusion with spoken language. Instead of ask, he will say ask. Difficulty learning alphabet sounds, and thereafter B for D, P for Q, PAT for TAP, DOG for GOD, so on and so forth. 4C is very clearly a child who has an issue with only academics. So vision and hearing has to be tested, but no other investigations required for this child. No MRI, no EEG, no genetic evaluations. Refer to an adolescent expert or a development pediatrician. Evaluations for learning disability. Don't forget comorbidities. He needs a program for academic, behavioral, emotional concerns, not just an IEP. No, not just an IEP, not just an interventional educational program. He needs also a behavioral program, also an emotional program. And that's why you need to refer to a pediatrician and not just a psychologist or a special educator. You need to monitor whether wherever you have sent, whether the child is getting the good results or no, and keep counseling the parents and the child appropriately. So in short, what will we do? These are all the terms we will stop using these terms as labels and not use these terms. Instead, take a simple history beginning with pregnancy, perinatal period, infancy, early childhood. IAP is doing such wonderful programs on early childhood development. Middle childhood is a very important term. Don't miss the history from 5-6 years onwards till about 11-12 years, because everybody is focusing on early development and adolescent. Arey, beech mein ka kya? Take the history of school behavior, whether his behavior is normal, what about his communication, and what about academics. Don't only focus on academics. Look at the history of parenting and peers, and finally, what are the punishments and that he has been facing at home. That is important. Very important, explore each symptom in some detail and explore symptoms in combination with each other is what we have tried to do today via this presentation. You know, all these examinations, very important, especially neurological signs and symptoms. Look for all these things. What shall we do? Simple things first. Counsel the parents about nutrition, parenting, screen time, developmental and behavioral screening, and about safety and security. And if this is not working out in way described so far in these cases, in your clinic, 2 months ho gaye, 3 months ho gaye, mool improvement dakhwat nahi hai, eye stressed hai, then you refer. But if you refer to somebody, ask that so-called expert, भाई तुझा diagnosis क्या है? Diagnosis क्या है आपका? नहीं, diagnosis कुछ नहीं. Refer to OT, refer to psychology and special education. Then it is better off with you only. No need to refer to such a so-called expert. Finally, keep in mind these very important things that will help you deal with these children. The most important thing that you need to counsel the parents is the importance of a schedule, the right time to wake up, what is to be done throughout the day, and the time to go to bed, and how to deal with the media as part of the schedule. You cannot stop an adolescence from the media, but you can restrict and limit it to certain times of the day. That is very, very important. Outdoor play, sports is the only way you can keep the child away from the media. Never forget to tell the parents that you told me 10 things that the child is not good at. What is he good at? Doctor, he's good at playing the piano, but we are not interested. वो बाजा थोड़ी बजाएगा जिंदगी भर. Tell them, please make sure he goes for the only one thing in the life that is keeping him happy and preventing him from suicide probably in the long run. Make sure you look at his likes, dislikes, aptitude. Don't make him do only those things in the day. All the day is full of dislikes, and there is not one likable thing in the day. Don't do that. Talk to the parent about it. Very important. Is there a history of marital discord in the family? How are the parents getting along with each other? Very important. What are the grandparents' values? What are the parents' values versus the grandparents' values? आई एक बोलते, आजी वेगळा काहीतरी बोलते. This is very important. And in red, criticism and trauma. That's why I put up that slide earlier. Trauma doesn't mean child sexual abuse, on which we have big conferences. It does not mean that रोजची खटखट is a trauma. That रोजची criticism is a trauma. तुम ये नहीं कर रहे, तुम वो नहीं कर रहे, इसको देखो, उसको देखो, तुम्हारे डॉक्टर को देखो, पड़ोस वाले को देखो. This is trauma. Over a period of time, how we behave with the adolescent leads to trauma. Good idea for you as a pediatrician to find out whom does he relate to, who are his role models, whom does he identify with. Very important in today's time, vaping is the new big problem, addiction in youngsters. Why? Because even the youngsters know today narcotics is dangerous, but somehow they've got this idea that vaping is a very, very safe thing. I'm sure somebody will talk about it later. A mnemonic, SAD, always look at signs of anxiety, depression, and suicide in the child. And of course, never ever miss to check a vision and hearing. So finally, take home messages just exactly 1 minute before I end. Do not be in a hurry to label the child, especially the symptoms like hyperactive hai, aggressive hai, behavioral problem hai, learning difficulty hai, not doing well, difficult adolescent. Is की छाया की में आड़ लेके आप मत भागिए. Don't refer the child, oh, difficult adolescent, let me refer to an adolescent consultant. ऐसा कुछ नहीं है. You need to go through the history that we described. Do not mistake symptoms for the disorder. Don't end by saying hyperactive child है, अभी जाके hyperactivity का treatment कराओ. ऐसा नहीं करना चाहिए. Hyperactivity is only a symptom. All these red labels above, red label sounds like a nice word, right? Hopefully next week at Nasik will confirm that. Hyperactive, aggressive, these are all symptoms. Don't consider that as diagnosis. You need to find out the underlying diagnosis in the way we described in the scenarios. Differentiate with reality and drama. Chief complaints to you will be, डॉक्टर मेरे को स्कूल जाने में शर्म आती है बच्चे के. क्यों? वो जाऊंगी तो टीचर्स कंप्लेंट करते हैं, सर्व पालक मला भेटतात, गेटवरच थांबवतात, काय तुमच्या मुलाने हे केलं, माझ्या मुलीला काहीतरी पत्र लिहितो, चिडवतो, आम्हाला सेफ वाटत नाही, मी काय करू? Stop. I understand. That's a situation. Agreed. But there's so much of drama around it. Don't forget the reality. What were the child symptoms? And hence we did all these scenarios today. In the way we did it, analyze the symptom or the symptoms, map the approach, look for comorbidities in the way we described all the 4 scenarios, but do not make the mistake of initiating symptom-based therapy or intervention. Behavioral problem hai, go to a behavioral therapist. Academic problem hai, go to a remedial educator. Speech problem hai, go to a speech therapist. कुछ problem है जो मुझे नहीं समझ रहा है, go to a psychologist, मुझे भी लेके जाओ. Don't do all this. We need to find the reason behind this, and it's not too difficult as you saw. This is possible. Whatever I've shared, my acknowledgements are to the Indian Academy of Pediatrics, our chapters of adolescents as well as developmental pediatrics. And finally, my wonderful team. This is a 5-year-old photo of the wonderful psychologists, therapists, special educators. We are all good if we work together. We are not good if we work separately in silos. And that's where the child and the family gets confused. This is a book by Indian Academy of Pediatrics, Handbook of Developmental Behavioral Pediatrics, available at medical stores. So if you would like to know some details, in short, without too much of text, you can refer to this. Finally, an invitation on behalf of Central IIP, Ramakant and myself to come for the next Pedicon. Dr. Upendra Kinzavdekar, our darling president, will be sworn in as the IIP president along with the 30th International Pediatric Association Conference. And thank you very much for an excellent participation from all of you. Unfortunately, it was only one way, but I hope I received some questions as well. Thank you once again to the organizers, our wonderful beloved Maha IIP, and all the great work all of you are doing for the academy. Thank you so much. You are on mute, Dr. Ram.
Really grateful to you, sir, for this wonderful talk with so many take-home messages and eye-opening messages. Don't be in hurry to label a child as aggressive, hyperactive, or difficult adolescent. Very important eye-opening message. Even if we scold the child, if we talk him with loud voice, it will create trauma to him. Then with whom the child talks, with peers, with social media, with God, that helps in identifying some spectrum diseases, like even can identify schizophrenia like things. Also very important not to miss neurometabolic diseases as well as any diseases related with sense organs. And also most important, as far as possible, don't be in a hurry to outsource the child. Evaluate, counsel the parents, and try to manage the child. So really grateful to you, sir.
Thank you so much. Thank you.
Sir, one question from the audience. Sir, if some adolescent comes to us with some complaint like acute abdominal pain or some joint pain or some neck pain, and we have found nothing, it is only stress related. At that time, how can we counsel that child? How can we find whether he is in stress? Because we first give medications, then we do basic investigations like ultrasound or X-ray, and we found nothing. And we could see the stress on child's face, or we could see the child is disturbed. At that time, without getting direct question from the parents or child that I am stressed or I am not feeling well, I am feeling depressed, how can we approach the child for these things?
That's an excellent question. And there are some interesting messages that I'd like to share, which I've also learned from. Nothing direct works in adolescence. That's my suggestion. But the trouble is we have limited time and we have attended sessions where we have been given a checklist. So we want to finish the checklist. That checklist you should use for abdominal examination, for respiratory examination, for neurological examination. Udhar checklist chalta hai. In talking to a human being, checklist nahi chalta hai. In talking to a human being, it is very important first to have a rapport, और वो दिल से दिल मिलना चाहिए, मनो मैली पाहिजे. And for that, avoid the direct approach. Indirect approach, which is still very important, and that checklist you can use, is start with perinatal history, and that's why I showed that slide there. Take the general history. Very often it may not be directly contributory, but that helps you build up rapport without wasting time, because there may not be a problem at that time. So the parent is also comfortable, adolescent is comfortable talking about that. And it's always important to start with before birth, early infancy, toddlerhood, under 3, then middle childhood. All this history taking is very important. Just because the medical complaint, you have examined him and there are no medical signs, suddenly to call it psychosomatic is not a good idea. And then you are looking for stress. You are imagining that there is stress. You don't know. It could be anything. It could be depression. It could be anxiety. It could be boredom. It could be ADHD. It could be missed autism. It could be missed autism leading to anxiety because the child doesn't know what to do. The only answer is take a detailed history step by step that we have spoken. And the answer in a developmental behavioral and generally in an adolescent practice is always from the developmental behavioral history. You will get the red flags from the history and that will guide you what is going wrong. The last thing, never ever make a judgmental labeled diagnosis in 2 minutes. Never ever do that. Never ever do that. Because once you say psychosomatic, you will miss whether it is an anxiety coming up because of bullying in school or because of abuse by the stepfather or an alcoholic father or because there is an ADHD component which has been missed or an autism which has been missed. So always resist to conclude psychosomatic. हम क्या कर रहे हैं? Medical नहीं है. Inverted comma. Medical है तो ये क्या है? ये geographical है. Medical ही है. But psychological है. So go slow.
Thank you, sir. Thank you. Thanks a lot, sir. Thank you. So now we have learned initial assessment of adolescent child. When he has come to our OPD, we have assessed him. Now what will be next part? Of course, talking with the child, talking with the parent, and that is counseling. So counseling is arts as well as science, as we are very well aware. And counseling supports the growing kids' physical as well as emotional changes which they are going through. And they can help them to provide a safe space to process their thoughts and emotions where they are dealt with empathy, dignity, and respect. So counseling is very important part of managing an adolescent child. And for this very important session, this very important topic is covered in step 2 of this workshop. And for this step 2 of this workshop, we have Dr. Jayashree Shivalkar Madam from Nagpur, who is developmental pediatrician and child and adolescent psychologist. She is running Childhood Development and Activity Center at Nagpur. She is national level life skill trainer and she has written various articles on childhood development. She is executive member of Maharashtra State Activity Advisory Board on Disability. She is ex-president of Adolescent Health Academy Nagpur. She is joint secretary of GDBP, that is Growth Development and Behavioral Pediatrics IIP. She has conducted more than 100 workshops for parents, teachers, and students and rehabilitation professors. She is a member of State Council of Mental Health. This introduction, I request Dr. Jayashree Shivalkar Madam to guide us on basics of counseling and cognitive behavioral therapy. The topic is counseling made easy. Over to you, Dr. Jayashree Madam.
Yeah. Thank you so much. Good afternoon, everybody. Am I audible?
Yes, madam.
Yeah. So first of all, a big thank you to Dr. Gangolia sir, Dr. Pawar, and Dr. Samir Dalwai for giving me this opportunity for conducting this session, Basics of Counseling, with the focus on cognitive behavioral therapy. This, of course, is a topic for workshop, but today I have tried to frame it in such a way that we will understand the basics of CBT, and maybe sometime later we can have a full-fledged workshop on it. So Dr. Dalwai has excellently given us the framework of how to approach an adolescent with any issues in the OPD. And frequently the term counseling has been used by him. As it is, we are using counseling as doctors whenever we are talking with the patients or their parents, maybe during grief period, maybe during their family problems, and so many other opportunities. So basically, we are tuned with the counseling, but here in reference to adolescents, we need to understand counseling in little bit detail. So what is the need of understanding counseling? It is the term which is frequently used or misused, and somehow there are certain barriers in the mind of pediatricians, whether we can do it, we should do it, is it time consuming, is it effective, क्या सिर्फ बात करने से बात बन जाती है, is it useful? So there are many questions in the mind of pediatricians, and we need to understand that there is a definite process of counseling, there is a definite technique of counseling. So it is a structured way of communication with the client, or especially adolescent here we are referring to. So we need to understand these basics of counseling and where and when it is recommended and how to use it. So today we are going to look at it, and CBT, or what we call it as a cognitive behavioral therapy, is a foundation of counseling. And if we understand the basic techniques or basic framework of CBT, then probably we can go for some effective counseling, maybe in a little shorter time as well. So whenever we are talking of teenagers today, CBT or counseling is not used only for certain mental health disorder, but for even teens today, normal teens also, we need to have some counseling approach, maybe as a parent, maybe as a pediatrician, or maybe as a conscious citizen of this country. Okay. So what are the qualities of teens today? Most importantly, that they are deficient in interpersonal skills. So they don't want to talk to their parents, they don't want to talk to their teachers, they don't want to talk to pediatrician as well. So that quality is definitely there, which can be a barrier and we have to deal with. They are very skeptical. Isse kya hoga? Most of the time, the common problem with teenagers is related with academics, and the answer they give is कि पढ़ने से क्या होता है? We see in media there are hardly any person who are educated like that. They will talk to their parents. They are desensitized. More of a screen time, and that affects their sensitivity towards others, especially parents, and then it is difficult to communicate with them. They are supposed to be multitasker, they are supposed to be tech savvy, and if they are not, that can be a cause for stress, even for a normal teenager. They have, we see them at two extremes. On one hand, they are extremely ambitious. Even 9-10 standard will tell you, मुझे तो computer engineer ही बनना है. Maths weak है, but I want to be a computer engineer. Yeah, on the other hand, they see they are lazy, they are demotivated. We see so many graduates, engineers, they are just doing nothing. एक साल में break ले रहा हूँ. So there are two extremes which we have to deal with. There are very high expectations, even from self. I mean, they are also expecting a lot from themselves, and of course, their parents are expecting a lot from themselves. Maybe single child, maybe a precious child, so they have very high expectations. Day by day, this is a common observation that they have low tolerance and they are impatient. And they have a very strong peer connect. And in the last 2 years, we have seen that there is a confusion between real and real world. They are more into this real world, they are more into their virtual world, and it is difficult to connect with them on reality basis. So these are normal teenagers, and we have to deal with them also. And there also this counseling is helpful and effective. So as we all know, we have been dealing with this adolescent friendly initiative. So these are just basics that we have to verbalize confidentiality. This is very important. Don't take it for granted like adults, but we have to tell them that whatever you discuss is going to be within us only. We go ahead with the headaches. We have already done that. We will have to plan sessions with parents, without parents, maybe sometime combined sessions. So depending upon the situation, we have to plan the session. And definitely we have to give, especially if it is a general pediatrician, we have to plan a separate appointment. And gradually we have to make a habit to ourselves that yes, maybe half an hour, 1 hour to start with, but I will have a separate time for adolescent, and then gradually we can increase this time. And as Dr. Dalwai has said, that we need to develop confidence to manage these cases than refer. Many times we conduct these workshops, we hear these workshops, and many times in the treatment it is written refer to psychologist. But what we are going to do, if we are going to take the whole history and then refer to psychologist, do psychologists refer back to us? No, mostly no. Do they refer on their own to pediatrician? 100% no. It is only we who are referring them. So it is our patient, it is our teenager, and we have to retain them. And what guarantee do we have about those psychologists? Many times they are half-baked psychologists. Many times they have done just a 1-year diploma somewhere and they call themselves psychologists. They have big boards, big appointment schedules. They promote it like that, and we just refer them. So avoid referring to anybody whom you are not sure of, and avoid referring to somebody who is not going to give you feedback or who is not going to send you patient back to you. Second thing, many times we see that refer to psychiatrist. Whenever we refer to psychiatrist, the patient doesn't go there. That is the reality. You just write refer to the psychiatrist and the patient will not reach there. Firstly, they have barriers in their own mind. They have some stigma about them. Secondly, these normal behavioral teenage issues, and suddenly we refer to the psychologist, OPD full of schizophrenia, then naturally parents are going to get demotivated and the patient will not come back to you. So again, for this reason and a bit of training, we can have this patient with us, and it is fun to manage them and it is very rewarding to manage them. So today's session is for that one line which always hear in the treatment: counseling. So what exactly do we mean by that, and what exactly we do with the counseling? So here we have a very basic model of CBT, that is cognitive behavioral therapy, which is based on thought, feelings, and action. So whatever we do, it has to be associated with some or the other thought. It has to be associated with some or the other feeling and resulting action. So say for example, there is a plan for shopping. So a thought will come, mother and daughter are planning the shopping. They just say that, let's go for shopping. So that is a thought. And the mother will say, okay, what mother will think? Now I have to go to market. You know, I like the marketplace. I like to bargain. I like the colorful environment. So she's happy. So that thought comes to you, her mind. So feeling comes that she's happy. She's looking forward to it, and followed by action that she will go in a market to for shopping. The same thought comes to teenager mind. What she will think? Baap re, market jana hai, such a crowded place, and you know, वहाँ का वो salesman जल्दी जल्दी दिखाता भी नहीं है. You know, I have to wait there for so many hours, and you know, I just don't like it. So the feeling of going for shopping in market doesn't have any exciting feeling in the mind or emotion in the mind, and the action taken is that I will prefer online marketing, or I will go for online shopping. So a thought associated with feeling will result in the action, and this cycle is something which we are going to explore in our management. So CBT is a process. It's not one-time activity. It's a process of teaching, coaching, and reinforcing positive behavior. Since this is a one-way session, only I am talking. I don't have even eye contact with the audience, or I cannot take feedback from the audience. So you will have to bear with it, or you will have to keep your thinking process on to understand this subject, which is a little new for all of us. So CBT is a process which is reinforcing positive behavior to help the person rearrange thoughts and emotions, and definitely it will be associated with change in behavior. So this process we are going to explore in next few slides. So again, this is a model which we are going to see in little detail. Here we can see that there are feelings, there are thoughts, there are emotions, and there is behavior. And there are certain feelings, certain thoughts, certain emotions, and certain behavior just given as an example. So let us take the feeling, and it shows that beliefs and self-talk. This is just one example. So we have a standard 10 student who is an average student, routinely scoring approximately 70 to 75%. So what belief that student has about himself? उसको क्या लगता है कि I am an average student. When he talks to himself, he would probably reinforce his thoughts that I am an average student. And maybe his attitude is that I am okay with it. So he's studying normally, he's comfortably getting 70, 75%. Okay, now what happens? Now he enters standard 10th. So suddenly what parents feel, 75 is not enough, he has to at least go beyond 85%. So they talk with their approach towards child is that nahi, this is not enough. 85 ke aage to jana hi hai, and then about all the future talk, blah blah blah, they will start talking. Immediately the child enters standard 10. Okay, so now this talk is reflected, his feelings are now shifted to certain thoughts, which can go from negative to positive or from positive to negative. So if the thoughts are negative, associated with these parental expectations, the associated emotion will be of maybe anger, maybe irritation, maybe frustration. Okay, and what he will say, इनको बोलने को क्या जाता है, दिन भर तो मैं पढ़ ही रहा हूँ, हमारे टीचर ऐसे हैं, मुझे तो यही करना है, and that negative thought will be associated with negative emotion and the resultant behavior, which we can see in two forms, a physical and a physiological. The child will not be able to transform his way of study into more constructive way. But if the thoughts associated with the parental expectations, they are conveyed to him in certain different way, more supportive way, probably his thoughts would be positive. Probably his emotions would then be, okay, I will try. It is good to get good marks. Okay, so it will be transformed into his behavior, where on physical aspect, you will see that child is now showing bit of concentration, his sitting span is better, and he has planned some good goals for himself. And if it is negative, you can see that the child will, maybe he will sitting on the table, but he's not concentrating. He's all the time angry. His heart rate is more, he's anxious. So all these things are related. Why we are discussing this in detail? Because we have to not just target the behavior, because as we call it as a behavioral problem, but we have to focus on the underlying feelings, underlying thoughts, and underlying emotions, which may not be for just this time being, but this could be since his childhood, as we will see. So we have to have a dialogue, or we will have to have some interaction where we will be exploring all these things during our interview. So what we are going to do, we are going to discuss a case, and so that it will be a little easier for us to understand the process of counseling and CBT. So here we have a very simple case where 18-year-old girl we have, she's academically good student in a good college. Okay, but she's showing recent fall in grades and a change in behavior. And why she's now today with us is that she is very feeling sad, and the parents have told that she has literally thrown her mobile. And the reason is she was not invited for events on and off with her friends. Economically, she is weaker as compared to her peers, which is very common scenario where we see students of variety of economic status are studying together. And one additional point is that she is a good cook. Okay, so let us go ahead with this case. So whenever we have any teenager coming to us, we have to have certain things fixed in our mind, or we should be aware of these things. that the client or a teenager needs to be proactive. Sometimes, they are just sitting and staring at you, and you can see that they are not at all cooperative. You just can't have a breakthrough. So maybe we can have session at some different time. Maybe we can talk on something else and then start this counseling. So a client needs to be proactive, and there has to be motivation to change. And if that is not there, then it is our task to, initiate first that motivation to change, and then go ahead with a structured conversation. So it is not that we are just, having gappa. We are not just talking like this. We are talking with a very definite aim. We are talking with her with a definite structured plan in our mind. And on one hand, we are talking, we are discussing. On the other hand, at the back of our mind, we are observing her body language, we are observing her responses, we are observing her emotional expressions also. At the same time, at the back of our mind, our directive plan has started. So by the time the interview is over, we already have plan in our mind. So it is a directive plan. Simultaneously, we are doing that. And it is a collaborative interaction between the two of them. And we have to see that we keep our conversation problem oriented. We need not divert it in every other direction, so that otherwise it will be half an hour conversation and you don't know what the basic problem is. So you have to guide the interview in such a way that you get the required information, and at the same time you are focused on the problem. So here we know the problem, that she was angry, she was sad that she was not invited to certain event. Okay, so as we are now going for cognitive behavior therapy, we have to know that we have to focus. The therapy will be focusing on thoughts, it will be focusing on feelings, it is focusing on the problem, that we are problem focused, we are present centered. See, we need information in the what has happened in the past or childhood, or what she plans to do afterwards, but generally our conversation would focus on the current aspect. It is of course collaborative, client centered, and ultimately focused on behavior. So this is how our interview will go on. So as we all know, the ABC of behavior, A is antecedent event, B is behavior, C is consequences. Okay. So here in this case, the antecedent event was that she saw on her social media pictures of the party. She had a group of 10 friends. Out of them, 7 friends were having a good time in a very good place, maybe a costly place also. And suddenly she had a rush of thoughts कि देखो इन्होंने पार्टी कर ली है and I am not invited, and she is looking at the pictures and suddenly she is angry, irritated, and in that fit of anger her behavior is that she throws her mobile. And what is the consequence? The mother of course see that mobile is broken and in retrospect mother is also observing that her behavior is just not the same since past few days. Definitely it is going to lead to a certain dispute, and it is going to affect her behavior, her relationship, her performance, everything. And that is why they are here for the counseling. So here one thing just I want to clarify, that here in this case we are taking a very direct behavior कि mobile फेंक दिया, but behavior could be affective, it could be somatic, or it could be in action. What is affective? Affective is one step before that actual behavior. Like in this case, if you can imagine कि उसने mobile तोड़ा नहीं या फेंका नहीं, but in her mind she is angry, she is irritated, and she is frustrated, and she is just short of throwing her mobile, but definitely the impact is same. Somatic, mostly in children we see that sometimes they will say that I have pain in abdomen, sometimes they say that I have body ache, sometimes headache, just because to avoid school. So sometimes this behavior could not be direct, which can be seen by the parents, but it could be somatic, what we call as psychosomatic. And as we have seen in this case, that it was direct action that she has thrown the mobile. So we focus on this ABCD model, and this ABCD is model in reference to her current behavior. But with the interview, we have to focus on some other things. Now, what are these other things which we are referring to? So here you can see the basic triangle of core beliefs, and there are three things: yourself, that is the client; the others, that is the family maybe, and maybe what she is thinking in future. So here in this case, that girl is there and coming from not so good socioeconomic status, but utna bhi bura nahi hai, she's fairly good. Okay, but since childhood, she has had these thoughts, yaar kuch paise aur hote to maza aata. Sometimes, I have to compromise. She might tell you during the interview, when you are going ahead with the interview, हमेशा पैसे थोड़े कम ही पड़ते हैं. So I would have loved to go outside. या मेरे पास कपड़े अच्छे होते थे. या this would have happened. This would happen. So when you are talking to her in retrospect, you will see that this feeling of inferiority complex because of her weaker socioeconomic has been there since long. So this is not only today's event. That is there, and this should come out from the history. Similarly, she might tell you, वैसे college तो मेरा अच्छा है, friends भी अच्छे हैं. So that also will give you clue that she is good academically and she is in a good college, and friends are also not that bad. Now, why we are taking these points in the history? Because as I have already told you that during interview, our back mind is also working. You have to notice this, or you have to put it down. She is in good college, her friends are not that bad, and this issue, she has been sensitive about this since long. Now, what about the others in the family? If you ask them, yes, madam, मेरे दोनों parents working है, they are मेरे लिए तो उनके पास time है ही नहीं, but they are working hard. They are really working hard. So again, you get 2 points that probably she is having a feeling of neglect from the parent also, but at the same time, she is acknowledging the efforts of the parents. Again, these are the 2 points which we can use in the treatment process. And future, see, I am in a good college. I was a good student. अभी मेरे marks कम हुए हैं, but I was a good student. और मैं चाहती हूँ जितना जल्दी मुझे job मिल जाए, this, I want to get out of this financial problem, and I want to support my parents also. So again, here we are having some or the other clues, what she is planning in future. So this is a basic framework which we get from her history. So now you have pretty idea what has been her mindset, her core beliefs, which has affected her today's behavior, today's feeling, and today's thoughts. Okay, so maybe with this interview, we move ahead. And what has resulted, her core beliefs, her financial condition, everything other which we have discussed, has led to this unhelpful thinking style. Now, this we have to understand a bit. So what she is thinking now, they have not invited me for the party. Now her thinking is all or none. अब इसके बाद मैं जाऊंगी नहीं. See, I am not going to attend any party. In fact, मैं वो group भी छोड़ देने वाली और मैं उनसे बात भी नहीं करूंगी. So, just thinking like that, thought of this, all or nothing. Okay. Yeah, I am going to shout at them and telling them that you cannot party without me. This is now associated with emotion, which you can see is anger, aggression. So this is unhelpful thinking, all or nothing. Or sometimes it is emotional unreasoning. ये मेरे साथ ऐसे ही करते हैं हमेशा. मैं बचपन से ऐसे ही होते आ रहा है. And I am so feeling so sad, and I am angry also. And this happens always. So this is emotional unreasoning or catastrophic. मतलब एक बार नहीं बुलाया है, या हो सकता है 1-2 बार भी नहीं बुलाया है. So is it a so big catastrophe that you are throwing your 10,000 mobile when already you are economically on a marginal side? So was this event so catastrophic? Again, this is something we use it when we are going to change her pattern of thinking. Disqualifying positive component means what? No, just give a thought कि she is a good student and her friends are also good. तो उन्होंने इसको क्यों नहीं बुलाया? Why she was not invited? And I have written that on and off she is not invited for a party. So probably her friends are considerate. Her friends are aware of her financial status. और ये पार्टी थी तो थोड़ा सा कंट्री ज्यादा था expected. So probably they have not invited her and they felt कि इस बारे में उससे बात करना भी बहुत अच्छा नहीं लगता है. So they probably didn't invite. And sometimes it so happens in a group of 10 friends, there is one core group of 5 friends. So sometimes they party independently. So she is disqualifying this positive component. She has started mind reading. She has started कि वो मेरे बारे में क्या सोचते हैं. You know, they probably think कि I am not worth. See, वो तो हाई-फाई लोग हैं. वो क्यों मुझे बुलाएंगे? They don't want me in the group. They don't like me. वो मेरा ग्रुप क्या, कॉलेज में कोई मुझे किसी को मैं पसंद नहीं हूँ. वो टीचर्स भी ऐसे ही थे. So without any actual this thing, she has started mind reading of the others and making some basic assumptions, and that also is affecting her emotions and definitely her behavior. She is labeling herself for mostly negative this thing, and she is making future predictions. अब ये हमेशा ऐसे ही करेंगे और मेरे साथ ये हमेशा ऐसे ही होने वाला है. So you can imagine a simple episode with her basic mindset, beliefs. She has thought in such a way that has led to sadness, aggression, and the behavior which we have seen. So this is unhelpful thinking style which we have to deal in our counseling. So what is this counseling then? This is cognitive restructuring. And this is, we plan to, in a very systematic way, guided way, we plan to restructure the way she's thinking. So what do? We have to identify the trigger. What happened that day? Okay. Identify the emotion. Okay, this happened and this is what you felt. You can also intensify. Okay, on one end, on scale of 0 to 10, गुस्सा कितना आया था, sadness कितना लग रहा था. So probably she knows कि I can talk on these things in a very objective manner. Identify the thoughts, automatic thoughts. Now, what are these automatic thoughts? Let us have an example. Like in a family, a lady is arranging her cupboard. Normal day hai, or she is arranging her cupboard. And suddenly she finds one old sari. And now she has memories which are negative associated with this sari. So just that is the trigger. उसने वो साड़ी देख ली. And now what she will think? Oh my God, ये साड़ी मुझे वो मेरे ननद ने दी थी, and कैसे दी थी? She was such a insulting, इतना insult किया था उसने मेरा, सब लोगों को अच्छी दी, and see what she has given this to me, and blah blah blah. And in a matter of minutes, that cupboard arranging is, put aside, and her mind is having some racing thoughts about that event. Okay, and that thoughts will lead to definitely emotions, as we have seen. So she's immediately, for no obvious reason, the reason is in her mind, she is into suddenly negative thoughts. These are automatic thoughts. Now, looking at the sari, she has immediately started this thought. And her daughter or some son or maybe husband comes in the room and asks her something. And she just blurts out. See, you don't know what is happening to me. सब काम मुझे ही करना पड़ता है. And these are the in-laws and you are giving this, and कब से 10 years से मेरी insult हो रही है. You don't pay attention. And the poor family is, just confused. She was doing some work and suddenly what she has started speaking about some 10 years back event. These are automatic thoughts. And we do have habits of keeping these automatic thoughts in our mind especially of a negative kind. So you see a photo and suddenly you start thinking something very bad, and your behavior changes, emotion changes, and thoughts change. So we have to deal with these automatic thoughts also. Then the next step would be to challenge these thoughts and beliefs. So maybe here in this case, you can tell me if I am overshooting my time. So if in this case, you can challenge the thoughts. Do they ignore you every time? No, they don't ignore me every time, but this particular. So you can challenge the belief that if we have this economic problem, has your parents anytime compromised on your education? No, madam, they have never compromised on my education, and I'm very proud of my parents कि मुझे कॉलेज हमेशा अच्छा ही मिला है या मेरा एजुकेशन अच्छा ही रहा है. So this is the way you can challenge the thoughts and beliefs, and we plan to replace these unhelpful thoughts with helpful thoughts. And we plan to, or we intend to re-evaluate those beliefs, those thoughts, and those emotions which are really purposeless, which are really not helping that individual. And basically, we cannot change some things in our life, and just the emotion associated with them will be disturbing all the time. So that we have to talk to that client. So 3 C's of cognitive behavioral therapy, as we have to identify the thought that came before the emotion. So it is the change of thought process, maybe change of beliefs, change the thought to more accurate or helpful one, and check, reflect on how accurate, useful the thought is. And this is the training we give to that adolescent, that think of the thought, wait for a minute, wait for a few seconds, see if that thought is helpful, see if you can change it, see if you can check it, or maybe you can talk to me at that time, or at least you can send me a message that madam such and such thought has come to your mind. I'm always there to acknowledge that thought. So that way you can motivate them also to be in communication with you. Okay, so what we are going to tell them, practice, or what we are going to tell that girl, have a good self-talk. There are certain good things about you, and there are certain good things about your friends also, and generate healthy alternatives. Like, isn't it good that they didn't invite you? अगर वो invite करते थे, तो would you have said yes, considering the contrary? And the hotel was pretty, distance was also too much, cab भी लगती थी शायद, तो अच्छा है ना कि उन्होंने नहीं बुलाया है. So this is healthy alternative. And you had a outing with them last weekend. तुम लोग garden गए थे. It was fun time. Yes, it was fun time. Maybe we can motivate them to keep a mood diary. I am feeling good, I am not feeling good. Sometimes we tell them in our life skill workshop also, have a mood partner. Can you talk to somebody when you have a good mood, bad mood, sad mood, or whatever mood? Yes, or I can be your mood partner. So you can just send me a message as and when you feel. There are certain thinking traps. Like I told you, हमेशा ही मेरे साथ ऐसा होता है, या मैं ऐसी ही हूँ, या मेरे साथ ऐसे ही होने वाला है. So these are the connections which are already made in our brain. So these are thinking traps. So we cannot think of anything otherwise. So we have to break these thinking traps and give new perception of events. So she can look at the event, or maybe next time she will confide in one of the friends that yes, it's good that you didn't call me that day. It would have been difficult for me to say no, or more difficult to say yes. So better, यार next time ऐसा करना कि मुझे बता देना कि तुम लोग जा रहे हैं. So I'm not surprised, or I don't feel left out. Yeah, share with me that you are planning something. So these are new perceptions. So we have to change the thoughts to more realistic, rational, recharging, and reorganized way of thinking. So that is what we are going to do in our counseling session. So this is again one of the way, that is sport, have positive goals. So here in this case, she has used a sentence कि पता नहीं मैं कब मुझे अच्छा जॉब मिलता है, कब हम ये प्रॉब्लम से बाहर निकलते हैं. So maybe that is one thing which you can motivate. So positive goals. So you are in this year. When do you expect to get a job? So what should be your score or your aptitude to get a good job? So maybe these are our goals. So goals should be specific. They should be observable, time bound, and realistic. So maybe in the next session we can plan for some good goal setting where her mind is diverted or focused on her. In that way, she will be a better thinker, and it will affect her performance also. So what we are planning is behavior going towards either constructive side or destructive side. So there is event which could be external as we have seen, or which could be internal as we have seen in case of that lady who was arranging her cupboard. तो उसमें बाहर किसी को कुछ दिखा नहीं, हुआ भी नहीं था. Only thing that she saw that sari. The event could be related with the self also, or it could be related with the other also. It could be related with the past also, suddenly remembering, or it could be related with the prediction of future. ऐसे ही होने वाला है. So that is the event. The associated thoughts are affected by the attitude, the cultural rules, the beliefs, and the previous images of the events. And the associated emotion could be either healthy or unhealthy. And remember, it will have a somatic aspect as well. Just last few slides. So this is cognitive behavioral therapy, usually recommended for these teenage issues like addiction, anxieties, bipolar, even low self-esteem, phobia, schizophrenia, suicidal ideation, depression, and even otherwise normally also when they have certain day-to-day issues, which we cannot label it as any problem, but still the gray zone where they are actually not very where you can label them, but there are certain issues which need to be handled. So CBT can be used in that case also. So this is basics of CBT, which is the foundation of counseling, and it is good idea for pediatricians to get well versed. It is first practice on myself. I mean, first practice, pediatricians should practice on themselves so that their thinking starts in that direction. Maybe you can practice it in your family. There are certain issues with your children, maybe some relatives' children, or someone your friends' children, and then you can try it on your adolescent friends and patients also. So this is something which we can learn. It's something which you can practice. It is very rewarding also, and with practice you can improve yourself also, and definitely it will reflect on your practice also. So instead of referring here and there and losing the patients, it is better we keep practicing and have a rewarding what we can say as a teenager who is looking happy and enthusiastic. So thank you all for your patient listening, and thank you for giving me this opportunity. Thank you.
Sincere thanks, madam, for this illustrative talk on importance of counseling and counseling made easy, and also enlighten us on CBT, cognitive behavioral therapy, which works on three components: thoughts, feelings, and action. And cognitive behavioral therapy is process of teaching, coaching, and reinforcing positive behavior, as well as and to help that person in rearranging the thoughts and with emotions associated with behavior. And also, madam has explained there are certain cases which don't have motivation to change, and in that cases we have to arrange structural conversation. Also, madam has explained many innovative things like self-talk, mood diary, etc. Thanks a lot, madam, for this wonderful talk.
Thank you.
And we will discuss question answers about counseling after Tamburi sir's talk. So now we had examined an adolescent. We had approach to diagnosis. Now we had undergone counseling. Now, what next? Because it's a common psychology of our society. जब तक डॉक्टर दवाई देता नहीं, तब तक पेशेंट का सेटिस्फेक्शन नहीं होता है. So, after all comes the role of drug therapy. So, step 3 of this workshop, that is simple drug treatment for adolescents. And to enlighten us on this important topic, we have Dr. Suchit Tamboli sir, who is first pediatrician from Maharashtra to be awarded with PhD in pediatrics by MUHS. He has been awarded with India's topmost 25 pediatrician and most promising doctor in developmental and adolescent pediatricians in India. He is national executive member for and national executive member of Central IIP in 2017 and 19. He was faculty in various state, national, and international conferences. Sir is director of NABH pre-accredited hospital OPD and child development centers. Sir is national coordinator of an IIP action-based behavioral module in 2019-20. Sir is national convener and coordinator for development for all cradle to crayon, that is early intervention module. Sir is chairperson of Government of Maharashtra Disability Certification Program. Sir is executive national chairperson of IIP Growth and Developmental and Behavioral Pediatrician Chapter 2014 and 15. He was task force committee member for Ahmednagar district in 2020-21. He has published more than 15 papers in indexed journal and YouTube channel, which has more than 28 videos, and he has hobbies of singing, reading, as well as acting in dramas. So with this short introduction, I hand over to you, Dr. Tamboli sir, for your talk on drug therapy in adolescent.
सर अनम्यूट करा सर अनम्यूट करा परत स्टार्ट करा अनम्यूट करा
माझं सर
परत स्टार्ट करा सर नाही सुचित सरांचं
ओके सर
सुचित सर अजून अनम्यूट नाही झालेलं अनम्यूट करा सर
आवाज येतोय आता
येस सर येस
आता येतोय सर
at the outset I must thank Maharashtra IIP, Dr. Gangulia sir, Dr. Amol Pawar, and respected Dr. Ram sir for introduction, and I think Dr. Samir has given very nice talk regarding how to handle OPD patient at the OPD level adolescent patient, and madam has told regarding the counseling. But I think I will deal with the management part. I am purposefully telling management part because only drug management is not that which is should be advised for the adolescent behavioral problems. Hence, you know few things about management also apart from the medicine, because as Ram sir has rightly said that दवाई दी नाही डॉक्टर ही नाही असं आपल्याकडे मानलं जातं आणि ते त्याच्यामुळे पेशेंट आस्क यू कि अरे ये सब ठीक है डॉक्टर लेकिन मेडिसिन क्या दिया वो बोलो. So I am going to talk about medicines also, but most important thing is that you should know all other components of management also. So we are going to deal with the common problems like anxiety disorder, depression, then enuresis. So what are the common problems? 3-4 common problems we will deal with that, and then we'll consider what are the other part where medicine has to be used. So diagnosis is very important while giving management. So it is assumed that you have diagnosed that patient, and after the diagnosis, what management you are going to advise. So suppose it is a anxiety disorder like social anxiety, where you have to give behavioral therapy, as already madam has discussed about CBT, exposure therapy, pharmacological therapy, where SSRI, like selective serotonin reuptake inhibitors, are very effective at managing some symptoms, or beta blockers to curb fear response and reduce physical symptoms of anxiety, such as palpitations, are very commonly seen with the this thing. And I think it is very important that we should know how to actually use this medicine, because proper doses are very important, and that we are going to sorry. So treatment of anxiety disorder, actually treatment should target 3 interrelated symptoms, like physical symptoms where there is a rapid heartbeat, muscle tension, insomnia; cognitive symptoms like distortion of perception of threat, and avoidance and escape. So all these symptoms should be taken care of, and they should be actually treated with the medication whenever required. So behavioral therapy, we know that there are other methods like systematic desensitization, or exposure therapy, or modeling therapy, play therapy, school-based counseling. As today we are not going to go into the details of this behavioral therapy, so exposure and all other these medicines are there, talk therapies are there. But here which is important is that when we diagnose these children, like anxiety, generalized anxiety, by DSM-5 criteria, then what is the primary treatment? Sorry. Primary treatment is medication, sorry, CBT plus medication, and medication which can be used is SSRI and buspirone, or medication secondarily used is benzodiazepine. Or obsessive compulsive disorder. If you diagnose obsessive compulsive disorder, actually primary treatment is exposure, then response prevention, and SSRI and clomipramine or TCA. Then panic disorder, where panic disorder you have to treat with the either CBT and family therapy, and then SSRI, benzodiazepine or TCA. Post-traumatic disorder, where you have to use CBT, psychotherapy, or here we can use whenever medicines are required, TCA, SSRI and benzodiazepine, and then other drugs like propranolol or clonidine can be used, or carbamazepine even has been used. Separation anxiety disorder, here again CBT family therapy is important, which is primary treatment. And what is medication treatment which is primarily used is SSRI. Extremely sorry for bad cough I am having. Separation anxiety, actually selective mutism is I think many of us see these cases, like parents say that he talks at house very nicely, but किसी के सामने गया तो वो बिल्कुल नहीं बात करेगा, ना ही स्कूल में बात करेगा, ना ही आपके सामने बात करेगा. So selective mutism is a condition where they are very resistant to talk amongst other people, and in that case I have seen long-term SSRI we have used in such cases, because that they are very resistant cases, and SSRI has to be used in such cases. And it gives good result. Social phobia, again CBT plus SSRI or benzodiazepine. Specific phobia, CBT. These are the common seen. So here actually the chart also gives some idea regarding that generalized anxiety disorder, what are the discriminant features and all. I think we are not going to go into the details. We have seen what are the medicine to be given in which type of generalized anxiety or obsessive compulsive disorder. We have all seen what are the commonest. Then this is regarding depression. So DSM-5 is again diagnostic, but Beck's depression inventory is very simple method to diagnose depression. and it is available online free of charge. And you can use that in your OPD. If you use this basic depression inventory, it is very useful and it gives classification of depression, like normal, mild mood disturbances, or borderline clinical depression, moderate or severe or extreme depression. So it is very useful. And you can diagnose this depression with simple mnemonics. Then we can manage depression, which is very important. That supportive care from a medical provider, psychotherapy, antidepressant medication, and important that treatment should be customized to the adolescent and severity of the depression symptoms. So if it is a mild depression, give only counseling. Moderate depression, counseling plus therapy. Severe depression, you have to start with the therapy. That is very important. Then never ignore suicidal threat. If suicidal threat is there, you must start with the medicine. And drug of choice is SSRI. Again, never ignore suicide thought. Suicide prevention is very important. If we can prevent one suicide in even 1 year, it is very useful. Then treatment guidelines. Actually, here most important is that management of comorbid conditions also is important, and assessment of factors associated with poor responses. And treatment goals of therapy, actually it is very important that include improvement in function and resolution of depressive symptoms. Goals should be tracked in several domains like home, school, and peers. And monitoring is very important. So full resolution of symptoms should be there, and how it can be happen, that response can be diagnosed as when there is significant reduction in symptoms or no symptoms for 2 weeks, remission in period of more than 2 weeks or less than 2 months with few symptoms, recovery is absence of symptoms for more than 2 months. So recovery should be our goal. So psychoeducation should be given to the parents, then supportive treatment should be given to them, that staying positive, developing coping skill, connecting with loved ones, seeking out help. General advice for families should be given. Things which can do them relax. Things which can do them relax for the adolescents is very important. Then pediatric self-regulation technique like self-hypnosis, biofeedback, diaphragmatic breathing, progressive muscle relaxation, autogenic. All these are also very important self-regulation technique which can help depression patient. Then these are the classification of relaxation therapies. So you must know these relaxation therapies do help in case of this depression patient as well as anxiety patient also. So guided imagery, that is child is encouraged to imagine a calm and smoothing scene. So that type of things also helps them. Deep muscle relaxation, apan shavasana karayla sangto. So that is again very common. So muscle relaxation is very important. How actually parents can help by monitoring and management of academic disengagement is also important. Medication, biofeedback, and treatment guidance are very important, where drug management is important part, where we have to see that whether it is a bipolar depression or psychotic symptom or what type of depression is there. That is very important. So what is drug of choice is fluoxetine. So all pediatricians actually, they, in my opinion, they can use fluoxetine if this depression inventory says that the diagnosis is moderate to severe depression. Then, but the dose should be initially 10 milligram, then can be increased up to 20 milligram. But if it is more than 20 milligram is required, then it is better to take opinion of an psychiatrist. That is very important. So psychiatrist opinion is required if fluoxetine is not working for more than 20 milligram dose is required. Then there are other methods also can be used, or other drugs also can be used, but I think they should not be used in a primary stage. It should be used with the help of the psychiatrist. That will be better. So how much time you should give that medicine is very important. So there are 3 phases, like continue the drug for 4 to 6 weeks, where you have to define the target symptoms, look for the side effects, discuss side effects, and if response is inadequate, increase the dose. and continuation phase. So continuous same dose for 6 to 12 months. We have used this fluoxetine in many cases up to 1 year, or even more than 1 year in few cases where maintenance dose is required. So where more than 12 months required is multiple severe episode or family history of bipolar disorder. In that case, you have to use it for the longer period. Then resistant depression also is very important, where we can use with lithium can be augmented, or ECT can be added, optimization of dose and duration can be increased. Then there are investigational antidepressant therapy, which are there at present. They are in research stage, lamotrigine or reboxetine or riluzole. So all these are also again a good medication. It's likely to be come in near future. So this triple reuptake inhibitor, which is I think will be drug pipeline, serotonin, norepinephrine, and neurokinin antagonist. So that it is going to be newer in pipeline. So pediatrician actually is the first person who is contacted by the parents, and very important role in identification and treatment of depression. So diagnosis is simple without any costly investigation like Beck's depression inventory, and treatment is also simple. So first cognitive behavioral therapy as well as counseling, and then serotonin you can SSRI can be used. So improve the quality of life and his family and prevent morbidity and mortality. When there is no response, high risk of suicide, relapse of symptoms, or typical features, then you should refer to the psychiatrist. Here again, most important is that when it should be treated, developmental age of 7 years or more, and still he waits. So child must cry at night, then start wetting the bed. So bed wetting alarms and all other things should be used. And then actually here desmopressin nasal spray or imipramine are drugs which can be used. But imipramine, the rate of relapse is around 50%. So it is better to use bladder control training, then wake up the child after 90 minutes of sleep and ask him to void urine. Bell and pad alarms, these are available now in India, and they are very useful because with the concept of conditioning reflex, they definitely help the child, and it does have actually only 10% relapse rate. Encoparesis, here again, most important thing is that giardiasis should be ruled out, and then other treatment should be given, like punishment should not be there, but cleaning out, and in difficult cases, child psychologist should be involved. So here constipation is again one of the important factors to be ruled out. So constipation treatment should be given when you consider that. Then nail biting, again here main treatment is positive and negative reinforcement, and bandage or bitter substance are not actually useful. So complication can be paranoia, oral herpes, and vitiligo. So actually here important thing is that trace imitation, because even we see many cricketers biting their nails. So here and that is very important, and can be transference of thumb sucking habit. Actually tics are also common in adolescent age group, and here management is very important. So here medicine does have a role, where diazepam or clonidine helps to control the symptoms. Here only counseling may not be helpful. So here you have to give treatment with the medicine. Like in ADHD, we have to manage their hyperactivity with the medicine part, which is very important. Then bruxism, again, it can be a very common complaints which around 10 years of, and here we have to give emotional support. Parents should be reviewing fear and anxiety daily. Then psychological management is very important. We're encouraging interest and social activities. And here, what is important is that keep them engaged creatively. This is very important sentence, that keep them engaged creatively. So if you keep them engaged creatively with their interest and social activities, then definitely the stress will be reduced and their anxiety issues will be solved with not only with the medicine but with the by building coping skills and strengthening their existing support system. So then comes ODD. ODD again here very important, where we may have to use medication, but here prevention is again important. For them, parents should be calm and consistent. For any behavioral problem, they should encourage sleep, as Samir has told importance of sleep, balanced meal 1-to-1 time with your child, which he has already talked about that. So now these last 2-3 slides are very important, where we can see these are the drugs and these are indication and minimum age for which they are approved. So mixed amphetamine salt for ADHD for more than 3 years, dextroamphetamine ADHD more than 3 years, methylphenidate for ADHD more than 6 years. So that is the important age where it has been approved. Then atomoxetine more than 6 years. Then we are not going to go into the details of the drugs which we don't use regularly. Fluoxetine for depression and OCD. Then generalized anxiety disorder. Generalized anxiety disorder. Again, here important thing is to use and risperidone. See, risperidone we are using very commonly with the ADHD with autism, and here aggression and autism, risperidone is used. It is allowed for more than 6 years. For schizophrenia, more than 13 years, and for bipolar disorder, it is more than 10 years. Then imipramine for enuresis, more than 6 years. Then other medicines we are not using very commonly, but bipolar disorder, olanzapine, fluoxetine, which we can use more than 10 years. So this is very important slide prepared by Dr. M.K. Nair, and he has very rightly told about, see, risperidone is used in organic brain syndrome. And what is the dose? 0.25 to 1 milligram. What is the dosing per day? So OD to TID. And this is again, risperidone can be used for psychosis, but dose will be 2 to 4 milligram. Risperidone for autism, 0.25 to 1 milligram. Risperidone for tic, again 0.25 to 2 milligram. Then mania, risperidone plus or minus valparin, which is valproate, which is again can be used with that for 20 milligram per kg. And valproate can be alone used for conduct disorder. I have seen good results in conduct disorder with valproate. And again, for the depression, fluoxetine is important. Anxiety disorder, fluoxetine is important, where it can be used from 10 to 20 milligram. For anxiety disorder, it may be given in higher doses, but I think for more than 20 milligram, pediatrician should not go for fluoxetine. Atomoxetine, ADHD, again 1.2 to 1.8 milligram per kilogram. And imipramine, enuresis, 0.3 milligram per kilogram per body weight. So actually, these are the 5 drugs only which should be used as per Dr. MKC for this adolescent age group. And I think this is the thing which I remember. And this is my chart, which I have prepared, but this is a simple chart. You can, if anybody wants, I can give details also. But here behavioral problems are given. Common presentation age group is given. What are the facts? What are the acts? And what are the medication? So if you keep this chart in your table, then you can manage these children properly, because you know what are the facts, what are the acts, and what are the medication required, and how to handle these all behavioral problem like thumb sucking, breath holding, stubborn, media addiction, depression, conduct disorder, anxiety, and enuresis. Thank you very much for patient listening, and thanks a lot.
Thanks a lot, Dr. Suchit sir. You had explained medication as well as environmental modification for certain disorders. Thanks a lot. Here I note the presence of our senior and teacher, Dr. R.G. Patil sir from Nagpur. I welcome you, sir.
Oh.
So let us come to question answer session. A question for Suchit sir from audience. What
Yes.
is proper way to reduce and stop fluoxetine?
Yes. It's very important that it should be given around 4 to 6 weeks initial dose. Then if the symptoms are reduced, I have shown the slide about response, remission. So if response is there, remission is there for more than 2 months, if the symptoms are not there, then you can reduce the actually fluoxetine every weekly 5 milligrams, and for next maybe around 1 month it can be stopped. But if it is longer duration, like one year if we have to use, then it should be tapered for around 3 months.
Thank you, sir. Sir, one more question for Dr. Suchit sir. So we come across certain very common preparations like piracetam, and also certain Ayurvedic preparations,
Yeah.
which are promoted to control hyperexcitability, hyperactivity, and bedwetting. So are these really helpful?
No, they are say placebo, and this has been proved by Dr. M.K.C. Nair sir in his one of the paper regarding the piracetam, and he has proved that it is same as placebo. So don't use such medicines, and use proper medicine. Actually, ADHD, you can use atomoxetine. It is definitely a good drug. You can use risperidone if it is autism with ADHD, and definitely they are helpful. But all these other medications, there is no way to prove that they are scientifically useful. They are just means satisfaction for the patient by the doctor.
Thank you, sir. One question from audience to Dr. Jayashree, madam.
Yes.
Madam, sometimes we need structured counseling or structured conversation, and there is scenario somewhere that 3 generations are together: adolescent, parents, and grandparents also have equal influence. So in that, how to arrange structured counseling and structured conversation?
Okay. First of all, as we have discussed during the process, that we have to plan for separate interview with sometimes with parents, sometimes with teenager, and sometimes with grandparents independently. And second thing, we have to be very clear about their role. So grandparents also know how much the teenager is going to listen to them. And when he is not listening, it is more of that age problem rather than giving respect and all other things, because they take it very sensitively and they generalize it, today's such and all those things. So it is better to have a clear role defined for coming personally. And sometimes we see that there is a lot of interference, then personalized counseling for grandparents is also recommended.
Thank you, madam.
Thank
And there are certain taboos, like some medications, some Ayurvedic treatment, some jhad phuk wala things, and parents strongly believe in those things. So how to tackle such scenario?
See, I think this is very important question. Why this placebo work for this is because the way it is given by that practitioner. Because they are so convinced that take this medicine and you will be all right. So it is not the medicine, but it is the way that Ayurveda practitioner or probably some other is convincing them. What we usually say, autism ke liye there is no drug. Okay, but you take this. So already patient has doubts कि अभी तो इन्होंने बोला कि drugs नहीं है, and now you take this. So it is the way we deal, and that is why we need to have a bit of counseling approach while dealing with the parents and to avoid the medical shopping. Because it is natural that parents are going to go at other places and they do get misguided. Parents are taking years of homeopathy and Ayurvedic treatment, no behavior therapy. So, but the way they convince, ho jayega, so sometimes it is the way which we tell the parents that is important. So that is what something we need to highlight.
सर एकच कॉमेंट करायचं आहे की आपल्याकडे सर्वात डेंजरस वाक्य जे बोललं जातं डॉक्टरांकडून की जसं जसं वय वाढेल तसं बुद्धी वाढेल किंवा जसं जसं वय वाढेल तसं ते शांत होईल, असा जो प्रकार असतो, दॅट इज व्हेरी रॉंग दिस थिंग. दॅट ऍक्च्युअली दॅट शुड नॉट बी commented by the pediatrician or other practitioner also, and that's why they feel that even many parents do come to our place and say that that doctor has told that 5 years he will be normal, so we waited for 5 years. So how it is possible? Is that any magic which is going to happen on that 5 years or so that is not a wrong thing. So they give that actually फक्त महत्वाची गोष्ट काय असते की ते आशा दाखवतात की अरे हा होणार आहे, कधीतरी होणार आहे, चांगलं होईल, काळजी करू नका, तुम्ही हे घेत राहा असं. So that type of counseling they do, and that is very wrong for many times when there is a serious problem like depression, anxiety or other behavioral problems. It is very important that they should be diagnosed very early and should be treated properly. Means medication, actually you should not be hesitant to use medication. That is what I have felt in my practice, that only counseling many times doesn't help, and that's why in few cases where it is required, you must use medication, like that all five drugs I have quoted of Dr. N.K.C. Nair's slide. I think that is very important. So if that diagnosis is proper with the DSM-5 criteria or other methods, then you must go for the counseling as well as medication. Thank you, sir.
Thank you, sir. Thank you. So there are no more questions in chat box now. Now I request Dr. Neha Singh, who is editor of Maha IAP and Women's Committee member of Maha IAP, for vote of thanks. Over to you, Dr. Neha, madam.
Thank you so much, Ram sir. On behalf of Maha IAP, I thank all the three experts of today, Dr. Sameer sir, Jayashree ma'am, and Dr. Gangoli sir, for deliberating such wonderful talk today. Very well explained how to do adolescent assessment, counseling, and managing various issues of adolescent in our daily OPD. Tell me and I forget. Teach me and I may remember. Involve me and I learn. For the things we have to learn before we have to do them, we learn by doing them. I hope all the attendees of today, as well as viewers who will be watching this recorded program later on, I'm sure they all will be enlightened and will be applying this knowledge in their practices. I would like to thank Maha IAP President Dr. Gangolia sir, Maha IAP Secretary General Amol Pawar sir, today's both Chairperson Ramakant Patil sir and President sir for today's program. Also would like to thank Ram Bharat sir for moderating this workshop, Vishal sir for the beautiful flyers, Pallavi ma'am for the technical support, all the attendees on Zoom as well as YouTube Live for joining us today. Thank you so much. And please don't forget to join us today at 9 p.m. for a subspecialty chapter, as well as tomorrow again at 9 p.m. for the adolescent.